Hello, my name is Steven Zuckerman, and I'm a neurologist in Baton Rouge, Louisiana, and I'm going to subject you to a discussion or review session on the Porphyrias. Now, you may wonder why I'm doing this. I don't know, but let's see how it goes. So this talk is going to concentrate on number one, defining what the porphyrias are. Number two, when would you suspect a porphyria in your patient, i.e. the clinical manifestations which would make the astute clinicians that you're no doubt are think of that diagnosis. Three, how would you go about confirming laboratory-wise the diagnosis? And number four, of course, would be management, how to treat these people so that they end up having the best quality of life available. So in answer to the first question, what are they? Well, all of the porphyrias are metabolic disorders which affect one of the 8 enzymes necessary for heme biosynthesis. This results in the accumulation of porphyrins, which are toxic, which could end up affecting the nervous system, the skin, or a combination of the above. And each different porphyria, in addition to having a unique enzyme which is deficient, also has a unique clinical picture and biochemical profile with the accumulation of the heme precursors. So that pretty much tells you what they are. And going a little bit more into the biochemistry, this, of course, everybody recognizes without even thinking about it as the heme molecule. And again, there are 8 different enzymes, which, if you would like to memorize them, you can come back to this video and stop it at this point, or actually stop it at the next sort of slide, which shows in order the different enzymes that are necessary for heme production. Then it is listed where they are located in the cell, either the mitochondria with 5 of them, and apparently 3 are located in the cytosol. Here are the genetic symbols, and this last column tells us how many mutations have been already recognized, which contribute to the dysfunction of those various heme enzyme producing cells or production. And here we have which ones are located in the mitochondria, which ones in the cytosol. And this is not particularly important information in regards to clinical application, since you would think that perhaps the ones in the mitochondria are also responsible for mitochondrial dysfunction, but that is not necessarily the case. And porphyrins are the major precursors of heme, which is important for hemoglobin, obviously the oxygen carrying molecule, myoglobin for the muscles, and the liver. Heme is important for P450 enzymes, and so if there's an increased concentration of the heme precursors and P450 is not made, there is toxicity from the precursors as well as dysfunction of the metabolic pathways for breakdown of various substances. Alrighty then. We mentioned that hemoglobin is formed from heme, and that takes place in the bone marrow. And there is these 5 disease entities, porphyrias, which are due to dysfunction of the hepatic enzymes in heme production, the P450 ones. So the most common one is actually this Porphyria cutanea tarda, which has skin manifestations, acute intermittent porphyria, which has nervous system involvement, and there are some which have both the possibility of cutaneous and nervous system involvement. So we already have a breakdown of the different kinds of porphyrias. Number one, depending on where the enzyme is located in the body, either erythropoietic or hepatic, and whether or not it causes acute neurological symptoms or chronic cutaneous symptoms. And we'll go back to that. Now, these are very rare disorders, with the incidence of acute intermittent porphyria estimated to be between 5 and 10 per 100K, whereas variegate porphyria may have about the same per million, but only 3 per million are symptomatic. So again, these are very rare disorders, and so why are you watching this video? I don't really know, but I'm going to tell you why I'm giving this talk in about 2 minutes. So again, we'll go over the clinical presentations. We can break down nervous system to an acute, and the cutaneous involvement can be acute, non-blistering, which is erythropoietic porphyria, which is the #1 porphyria in children, but only #3 in adults. And the chronic blistering is Porphyria cutanea tarda, which is the #1 porphyria. And then finally, this acute intermittent porphyria is the #2 porphyria. All the other ones are even more rare than above. So let's go over the differences between the neurological symptoms and the cutaneous ones. When there is neurological involvement with an acute attack, it is termed neurovisceral, which I think is an awesome term, and I like to throw that into sentences in everyday conversation, but can't say that I succeed very often. So you have nervous system and abdominal involvement. Now, the nervous system can affect all 3 different parts of the nervous system. So, central nervous system, it can involve the brain, and typically with an acute attack of porphyria, there is confusion and psychosis with psychiatric changes. There can also be seizures. Then there can be visual involvement. In fact, MRI scans can show what appears to be PRES, posterior reversible encephalopathy syndrome, changes. The peripheral nervous system can manifest with neuropathies, so either a sensory neuropathy or sensory motor neuropathy with involvement with the peripheral nervous system. And then finally, there could be involvement with the autonomic nervous system, and so you can have high blood pressure, low blood pressure, tachycardia, bradycardia, GI symptoms of nausea, vomiting, as well as constipation. But most remarkably is usually the abdominal pains. And here is a slide showing the potential involvement of the psychiatric involvement, abdominal pains with normal exams, peripheral vision disturbances, nausea, vomiting. There can be hyponatremia, hypokalemia. It can be a very dramatic and even life-threatening attack. So being able to recognize it obviously depends on thinking about it, and once that's done, you can do the necessary tests to exclude that possibility. Now, I want to mention variegate porphyria because this is a product of my whole exome sequencing, in which my protoporphyrinogen oxidase was shown to be pathological, and so I have the tendency to develop some of the symptoms, or all of the symptoms actually, of variegate porphyria. It's nothing that I'm very proud of, but at least it did induce me to go ahead and prepare this little talk. Now, variegate porphyria can either have nervous system involvement or cutaneous involvement. And this is a picture of the chronic, non-blistering manifestations of the disease, as well as this. And so that is a review of the Porphyrias to some extent. Now, the variegate porphyria, it was suspected that King George III of England in 1787, he was the king when the United States gained its independence, and he was known to have psychiatric disorders. And in the mid-60s, there were some British psychiatrists who suspected that he might have porphyria based on his intermittent manifestations of craziness and supposedly reporting of a purple urine. Now, this theory was made into a play in the 1980s, The Madness of King George, and here during the play they are depicting what was the most common treatment of such disorders, which was to strap you to a chair and leave you there, apparently. I'm not sure more current therapeutic interventions are more sophisticated than that. Then they made a movie out of that play, The Madness of King George, which actually apparently won some Academy Awards for set design and costume. And this was in the 1990s. And just to show you,
just a man.
His Majesty is out of his mind.
It's unthinkable.
Do you think that you are mad?
I hear the words, so I have to speak.
I was given to understand you might be able to cure His Majesty.
Well, I can cure him, Mr. Pitt. I'm just not sure what from.
I make the weather by means of mental powers.
The king is incapacitated.
If a few colonists in America can send him packing, why can't we?
He is to rule in your place.
By whose authority?
Now is the time, Charles!
Give us the wisdom of America.
From the award-winning director of Miss Saigon, the Samuel Goldwyn Company presents a story.
It was something he ate.
About a time of grace, grandeur, and the delicate balance of power.
Smiling babe. What you're paid for.
The madness of King George.
How is your Majesty?
Fat lot you care. God save the king. And so on.
okay, so I'm sure everybody's going to go online and try and look to see if they can stream that movie. I would highly recommend it. All right, so we reviewed the nervous system involvement and the cutaneous involvement. Now, let's talk about the polycythemia cutanea tarda. This porphyria is what gave people with the disease the suspicion of being vampires. And that's how we got porphyria being called vampire disease, because the porphyrins accumulating in the skin are highly photosensitive. And so therefore, people with this disease or this disorder avoided going out in the sunlight at all costs, and they would come out at night, and that's what gave them a bad rep. I should also mention that the toxin which accumulates for the central nervous system, peripheral nervous system, is more delta aminolevulinic acid, and so we've got another dichotomy of accumulation of toxins. One, the delta aminolevulinic acid for the central nervous system, etc., and the porphyrins for the skin manifestations. And here's an interesting slide, which again you can come back and try and read, which shows the clinical breakdown. So AIP, acute intermittent porphyria, being an acute attack of nervous system, etc. The PCT, porphyria cutaneous tarda, with cutaneous manifestations of a chronic non-blistering type, and that EPP, which is number 1 in kids and number 3 in adults, with the acute non-blistering manifestations. Down below are the other porphyrias, and I just want to point out variegate porphyria straddles both nervous system and cutaneous potential. Now, there are some environmental factors which can tend to increase your risk of precipitating in a porphyric attack, if that's a word. And so those would include smoking and tobacco, or tobacco and smoking, or both. They can increase or induce the cytochrome P450, which then diminishes the pool of the hepatic porphyrias and induces the porphyrin pathway and increased synthesis of heme precursors. So once you identify a patient who has a porphyria, it behooves you to get them to stop smoking and drinking, if at all possible. Another potential trigger for a porphyric attack would be certain medications, and in particular sex hormones such as progesterone can induce an attack, but anesthesia is also known to induce or trigger a porphyric attack. Another trigger would be a diet which is low in carbohydrates, and particularly if there is fasting, that can be a very potent trigger of a porphyria. And then finally, any intercurrent illness can cause stress, increasing the risk for porphyria. Now, how do you make the diagnosis? Well, these are the tests that one obtains. So, a spot urine for porphobilinogen, or one of these other tests, depending on which clinical feature is present and therefore which porphyria is highly suspected. But obtaining a urinary porphobilinogen, if it's very elevated, is highly sensitive, but one may need to repeat the test during an attack in order to obtain a positive result. Here is my result. It was negative, so you would think I didn't have symptomatic porphyria, but I'm not going to take progesterone just in case. And here is a list of what you test for depending on the clinical manifestation, and I'll see you back here in case you have a patient with one of the above syndromes that you're wondering what lab tests to send off. And finally, let's discuss a little bit about treatment. Again, if there's an acute attack, it can be a medical emergency, so it requires supportive care, i.e. fluid and electrolyte balance, perhaps analgesics if there's a lot of abdominal pain, antiepileptics if there are seizures, antipsychotics if there are behavioral manifestations. But everybody should get glucose, since again that suppresses the heme synthesis pathway. And there is a medicine, Heme, which also stops those enzymes. So Heme is a type of porphyrin, but it contains ferric instead of ferrous ion and chloride, and it inhibits the whole porphyrin / heme synthesis pathway. And in 2019, the FDA approved Givosiran, which, as opposed to the Heme, which is an IV infusion, this is a monthly subcutaneous injection designed to decrease the frequency and intensity of any attacks. So, in terms of chronic management, it takes a village. Well, actually, a team of people, a physician who is familiar with porphyria and its management. A pharmacist would be useful to make sure that the patient is not exposed to any medications which can induce an attack. Then somebody, one of these people, to get on their case about not smoking and drinking. There could be a dietitian to recommend carbohydrate containing foods so as to avoid fasting and low carbohydrate meals. And then finally, perhaps an OBGYN for the female patients to provide a gonadotropin releasing hormone, which would suppress ovulation. So it's not just one person, it's several people who would be involved in the long-term care of the porphyric patient. And with that, I would like to wish everybody a thank you very much for listening to me, and hope you got something out of this. Hope you did. Thanks.